Level of T10. Can they still stand on their right toes? First of all, corticospinal. Is this motor or sensory? Motor. Where does motor cross over? The medulla. So everything below that, damage is going to be ipsilateral or contralateral? Ipsilateral. So can this patient with a left lateral corticospinal tract damage still stand on their right toes? Yes, because its ipsilateral side is affected, the same side. Because this is motor. So when you're studying, again, make sure you know where the crossovers occur. Doing a physical exam on a patient, they fell off the ladder. He can't feel any pressure in the right foot. So the sensory issue is light touch and pressure. Which tract is damaged? First of all, is it a spinothalamic tract or a corticospinal tract? Spinothalamic. So that's half of your answer done right there. Now, he has a problem with his right foot. So what side is going to be affected before we even know what tract it's going to go in, if it's anterior or lateral? Left side. So what tract? Now you got to figure out, okay, fine, what's the final tract that it goes in? Left anterior spinothalamic. So light touch and pressure is the anterior one. What goes on the lateral spinothalamic tract? Pain and temperature. And what's the name of the structure that motor neurons decussate or cross over? So remember, decussate, you may see that word as well. Decussate just means crossover. Okay, so where does this go? Yep. Pyramids in the lower medulla. This is motor. They cross over in the medulla. Okay. What does the communication between the upper motor neuron and the lower motor neuron occur? Where is the synapse? The anterior gray horns. Very good. What's the major stimulatory neurotransmitter in the brain? Glutamate, right? Glutamate is the major stimulatory one in the brain. What's the major stimulatory neurotransmitter in the body? Acetylcholine. That's where the big difference occurs. There's more glutamate in the brain. What artery is responsible for supplying the precentral gyrus? Is that motor or sensory? Motor. That allows for your toes to wiggle. So this is about blood supply. So the lower extremity, what part of the brain is it? Then you got to figure out, okay, what's the blood supply to that part? So for lower extremity, what's the blood supply? Is it the anterior cerebral artery, middle cerebral artery, or posterior cerebral artery? This is the anterior one. Anterior is your lower extremity. Middle cerebral is mainly your face and the arms. If it was a posterior cerebral artery infarction or something wrong with the posterior cerebral artery, what kind of things would I be talking about? Vision problems. That's where our primary motor cortex is, in the occipital region. So that's posterior supply. So what are some examples of a finding in someone with an upper motor neuron lesion? Hyperreflexia. Positive what? Babinski. Okay. Normal muscle until disuse atrophy. Okay. Increased tone, hyperreflexia. Babinski shows upgoing toes. So these are for upper motor neuron lesions. What are the subcortical centers? We kind of mentioned them briefly, but again, this is basically your basal ganglia and stuff like that. I don't go into much detail about that, but basal ganglia and then your diencephalon, which I told you, make sure you know what that one was in our development embryology. The diencephalon forms in the mature baby, the thalamus and the hypothalamus. What are some signs and symptoms of anticholinergic syndrome? So you're taking these anticholinergic drugs for a long period of time. It's the whole nursery rhyme. I want to show one thing. So this whole thing right here, that dry as a bone, dry skin, also goes with, well, it's that one, I guess you could say that one. Dry mouth. You're dry. So remember we talked about one of the diseases, we said we're going to give them an anticholinergic drug to stop the lacrimation from the salivary glands. Yes?
Does that primarily affect the parasympathetic nervous system?
Well, remember, in the sympathetic nervous system, where do they go through first? And what neurotransmitter is at the ganglia? And there's your answer. Mainly going to have parasympathetic symptoms, but sweating, flushing is a sympathetic response. So it's still blocking acetylcholine at the sympathetic side chain ganglia. So if someone suffered a total spinal cord transection, what are some things we have to be worried about now for this patient going forward? They already had the event. We can't go back and fix any of that. We have to worry about them going forward and taking care of them. What are some things we have to worry about? Respirations. Can they support their respirations or not? What else? Pressure ulcers. What do you have to do? Turn the bed, use an air mattress. Okay, what else? Stress ulcers, so give them PPIs. Venous stasis, you want to prevent clots. So what kind of things can you do? You can answer. You started it. Not aspirin, for clots. Heparin, Lovenox. What also can you use? Very mechanical devices. So the compression devices, the SCDs. What else? What about breathing? What about eating? Okay, if they can't swallow, they can't eat, eventually you have to worry about J tubes or G tubes. What about vital signs? We mentioned breathing. What about just everything else? So neurogenic shock is that big one. And then remember what kind of shock it is. Distributive shock. Okay. Respiratory failure, we talked about DVT-PE, we talked about pressure sores, temperature control. The paralytic ileus deals with the GI and can things move. And your nutrition support, how can they eat? So again, these are the global things to start thinking of when you deal with patients who obviously have limited mobility. What do you have to do and worry about them going forward? Okay, 23-year-old male got shanked in the back. Immediate loss of pain and temperature on the left. Hyperreflexia on the right from his umbilicus on down. So where is the lesion? Pain and temperature are immediately lost. Hyperreflexia on the right from the umbilicus on down. So where is the lesion? First of all, are we talking about the right side or left side? Why the left? Contralateral. The hyperreflexia refers to what? Upper motor neuron problem. This is Brown-Séquard, and it's right T10. I mentioned the umbilicus, so just know umbilicus again, T10. I use it a lot. It's easy to remember. So T10. Okay, we just went through Brown-Séquard yesterday, but again, usually anything talk about getting stabbed in the back, think Brown-Séquard. It's a penetrating injury. It doesn't go through the entire spinal cord, just parts of it. That's how you get that problem. 42-year-old male suffered a fall. Since then, he's developed bladder or bowel incontinence. Also, numbness in both buttocks and inner thighs. What's that known as? Well, what's the symptom right here? With numbness in both buttocks and the groin. Saddle anesthesia. He's got bowel incontinence. He can't hold on to his bowels anymore because those nerves are damaged. So what's your plan for this patient? What are you worried about? This is your cauda equina syndrome. And if you have that, what do you have to do immediately? Get neurosurgeon involved. Well, what imaging study do you want to do? MRI, very good. urgent MRI, and emergent consult with neurosurgery. Okay, again, cauda equina. You're going to start getting a lot of questions like this going forward, these second order type questions where we just give you these are the symptoms, and we may say, what's your first line in treatment? We don't give you the diagnosis, you got to figure out the diagnosis. If you've picked the wrong diagnosis, you may pick the wrong test. We don't give you the diagnosis anymore. 50-year-old male, progressively worsening speaking over the past 6 months. So what muscles are now affected? The muscles around the mouth are called cortical bulbar involvement, problems with the lips and moving. Tongue fasciculations. So what diagnosis do you think this person might have? What are you thinking? ALS? What else? So what do you want to do? What are some things we do for ALS? Muscle biopsy and what other biopsy do you want to do? Nerve biopsy. Muscle biopsy, you want to see if there's any denervation atrophy because the nerve pulled apart, or get a look at the nerve itself and see what's going on with the nerve itself. Age matters as well, guys. Make sure you always check the ages. Remember, I got you guys on that aortic stenosis question in patho. Okay, the age matters. Remember, we go through etiology. When do these things start cropping up? You know, third and fourth decade of life. He's 50 years old. Okay, 68-year-old female presents with weakness and radicular sensory deficits for 1 month. Also reports some incontinence. What is the most important question to ask this patient to rule in or rule out a serious diagnosis? Epidural spinal cord compression. So you got pain. Now, I didn't really mention anything about pain worse at night, but you want to find out, is the pain worse when you lie down flat? When you go to bed at night, is the pain worse? Because you want to rule out an epidural spinal cord compression, meaning they have a tumor on the spinal cord that when you lay flat, it gets compressed and pinches the spinal cord, giving you radicular symptoms because that spinal cord tumor is compressing the nerves. Okay, what are the 2 tests you'll do to diagnose carpal tunnel? What's it called? So Tinel and Phelan's. Okay, Tinel, arms like this, and Phelan, you just start hitting that median nerve and see if it produces paresthesias. So Phelan and Tinel's. Okay, what's a systemic or metabolic disorder that results in a peripheral neuropathy? We all know diabetes. What else could be there? B12 deficiency, alcoholism, leprosy, these are all peripheral neuropathies. Okay, other examples. You suspect your patient has MS. You perform a lumbar puncture. What do you expect to see on the lumbar puncture? What protein? Why protein goes up? Myelin. What else do you see? What's the pathognomonic for MS? Oligoclonal bands. That's the key one. We're going to talk about CSF more when we get to meningitis and when we get to subarachnoid hemorrhages. So that will come back up. You notice a maculopapular rash along a dermatome pattern. Patient reports a lot of pain. What's your first line therapy? Your cyclovir, valacyclovir. Now, pain management. What do you treat with, what kind of medicine do you give for these patients? Gabapentin. This is nerve pain. This is not musculoskeletal pain. So like NSAIDs won't do much. You have to give the neuropathic drugs, gabapentin, Lyrica, Neurontin. Those will help with the nerve pain. First line therapy for a patient with diabetic peripheral neuropathy. Glucose control, always. Then once it's controlled and they still have it, you can add in your neuropathic pain meds, TCAs and your gabapentin and Neurontin. This disease binds irreversibly to receptors blocking the release of GABA. So what does GABA do? It's inhibitory. So if I'm blocking your inhibition, how will you always remain? Flexed. And what disease do we learn about that causes flexion and constant tetanus? Very good. Blocks GABA, no inhibition, our muscles stay contracted. This disease binds to the presynaptic side, so make sure when you're studying the neuromuscular junction, some of them are pre, some of them are post. Disrupts acetylcholine release. What's your treatment? So what's the problem here, first of all? Botulism. This is Botox. Blocks ACH from the presynaptic side. What does myasthenia gravis do? Postsynaptic side, those acetylcholine receptors, it blocks those. A 28-year-old female presents with muscle weakness and fatigue. You do a tensilon test, and it shows improvement. What was the tensilon test? We mentioned yesterday. The hand grip strength, and you give them a drug that has an acetylcholinesterase inhibitor. So you give them this drug, acetylcholine lasts longer in the synaptic cleft, and you get an improvement in hand grip strength. So we know that works. So what disease are we talking about? This is your myasthenia gravis. So what kind of drugs do we give? Acetylcholinesterase inhibitors. And the big one, also don't forget about the thymectomy. All myasthenia gravis patients should have a thymectomy. Why? 10% will have cancer of the thymus gland. Just take it out. And then obviously immunosuppressant therapy if you need to take it out. This disease is inherited, so it's inherited, resulting in progressive muscle weakness and wasting. What disease are we talking about? We haven't even talked about Parkinson's this unit. No. This is not cerebral palsy. Muscular dystrophy. Why? Muscular dystrophy is a genetic inherited component. Cerebral palsy is a defect in development. Okay, nothing to do with genetics. It's not inherited. It's a problem with either the way that you were born or something in development. So, muscular dystrophy, what do we have to worry about? Treatment for these patients. Just like those total spinal cord transections, no specific treatment, but lifestyle changes. Make sure they're keeping active, they keep moving, stuff like that. So if they're in bed for a long period of time, those air mattresses again, watch out for pressure sores and stuff like that. And then do we lose connection here? No, we're still going. There. Well, the last one, just cerebral palsy. Okay. Why is this just not working?
I think we've lost internet.
Oh, really? Internet's out for everyone? That'll do it. Okay, let me just pause. Okay, this disease caused due to abnormalities in the developing fetus or infantile brain resulting in permanent, non-progressive motor dysfunction. Which one is this one? This is your cerebral palsy. I'll post this all for you guys later. The audio will still be recording right now, so the audio is still going, but obviously there's no internet. But it did? Let's give it a second. Anyway, what are some differences between dizziness and vertigo? What's vertigo? That's when things are spinning. So the room is either spinning or you're spinning. Dizziness is just like lightheadedness, and so forth. Until that pops up. Okay. Okay, you perform a Dix-Hall pike and you notice the patient gets severe vertigo. Is this a central problem or a peripheral problem? Peripheral, they get severe vertigo at first. What are some treatments for Meniere's disease? Diuretics, we want to reduce the what? What's high in Meniere's disease? The fluid in the ear, the endolymph. There's too much of it. And it gives the oral pressure, A-U-R-A-L, oral, not O-R-A-L. So it's oral pressure in the ear. So you want to reduce all that. What's the biggest thing we do for dizziness? What's the drugs we give for dizziness? Meclizine or scopolamine, the patch. And what is a treatment for a BPPV? What's it called? Epley maneuver. That helps with that as well. Okay. Not really. Yeah, I'll see them later, I'm sure.
I'm here to sit there during the test and say, I remember all the funny ones. So I did.
Okay, we'll get started. Okay, what does the neural tube develop into? Even if you didn't know the answer, we know that the crest and the tube develop into different structures. One is central, one is peripheral, right? Cranial nerves, peripheral nervous system, brachial plexus, they're all peripheral nerves. The only one that's central is obviously the CNS. So again, you can work backwards. If you didn't know which one was which, look at the answers, work backwards. The neural crest differentiates into all the following except which structure? Very similar to the first one. Spinal cord. Okay, we just said before which one it does. So this is the only one that's central, the other ones are all peripheral. Vax for rabies already. Exciting. Okay, In order to prevent spina bifida, what should mothers take? Read. I told you day one.
I know that it's this.
Okay. Make sure you read all the words. Okay, these cells are the glue of the brain and resemble spiders. What cell structures? What do ependymal cells do? CSF fluid. What do Schwann cells do? Myelin. So these are your astrocytes. Okay, they're spiders. They have scaffolding, structural properties. What also do astrocytes do that's very important? Blood-brain barrier, very good. Okay, true or false? Okay, what's the answer? Schwann cells. Well, it's false, but it should be Schwann cells. Yes, that's right. Precentral gyrus is responsible for what? Okay, very good. Motor function is precentral. Which lobe is responsible for language and speech? Okay, now this is language and speech, but mainly comprehension. Like, do you understand what's going on? The questions. Do you understand what I'm saying? Language barriers. That's temporal. If I said motor function of actual speaking, that's frontal. That's where the Broca's area is. Remember, Broca's in the frontal. Wernicke's is in your temporal. And remember, guys, these are bad questions. I just make them up really fast. So on the test, obviously there'll be more information there. Pyramidal motor pathways are under voluntary control. True or false? Okay, this is true. The pyramids in the medulla are voluntary control. Anything that's outside of voluntary control, like coordination and stuff like that, is what? Extrapyramidal, okay? Coming from different areas outside the pyramids. Upper motor neurons lesions exhibit the following symptoms, except which one is not an upper motor neuron lesion? But you got two answers that are similar, so it's got to be one of those. Okay, down going toes. Very good. Lower motor neuron lesions exhibit the following symptoms except what? Again, we got two opposing answers. It's got to be one of those. Which one is it? very good. Hyperreflexia is not that's an upper motor neuron lesion. A lesion above the crossover of the motor tract causes motor impairment contralaterally or ipsilaterally. This is above the crossover. If we're above the crossover, think of strokes. Strokes occur above the crossover. The medulla is here. Strokes are in the brain itself. So if you have a right-sided stroke, contralateral side. Okay, this is above the crossover. That's why I always say you have to know where the crossovers occur and know what's going on above the lesion or below the lesion, or where the crossover is and where the lesion occurs. You got to know those crossovers. A lesion below the crossover in the medulla causes motor impairment ipsilateral. So think about right side T10. Go back to that T10. We know T10 is well below the crossover for motor. This will be ipsilateral loss below the crossover. Patient loses vibratory sense in the left hand. Where's the lesion? Okay, so vibratory sense follows what track? The dorsal white columns. Where does the dorsal white column cross over? In the medulla. So if I have problems with my left hand, my problem is in the left spinal cord as well, because it's the same pathway as going all the way up. So it's same side for the vibratory sense. If I said pain and temperature, it would be the opposite side, because they cross over early. I would have to give you more information about that. But also there's a crossover. Oh, yeah, the right side, as you were saying. Is this the correct order? Dura, pia, and arachnoid. Okay, false. Or dura, then arachnoid, then your pia. What's on the most outer surface? Dura. Blood collection between the skull and the dura is called what? So is the blood above the dura or below the dura? Above. So this is your epidural. Okay, what about the sympathetic nervous system? Short preganglionic, that releases acetylcholine. Long preganglionic, that releases acetylcholine. Long post preganglionic or short post? All sympathetic nerves will always have short preganglionic. Why is it short preganglionic? What's there? Your sympathetic side chain ganglion is right off the spinal cord. It goes right there for sympathetic. They have short preganglionic that release acetylcholine. After the ganglion, it's going to release, obviously, epinephrine, norepi, maybe dopamine in some places, but the postsynaptic, postganglionic is the one that's going to have the actual sympathetic neurotransmitters. Okay, similar question, but now we're talking about the parasympathetic nerves. So right off the bat, looking at the answers, we can get rid of 2 of them really easily. Because what don't they release? Parasympathetics never release norepinephrine or GABA. So those 2 answers could be gone right off the bat. Now we're left with the last 2. They're both acetylcholine, so we know that's parasympathetic. However, parasympathetics have long preganglionic short post. Okay, so it's the opposite. Parasympathetic and sympathetic are opposite when it comes to how long that first neuron is before you get to the ganglion. GABA is the major stimulating neurotransmitter, true or false? Okay, this is false. It's the major inhibitory neurotransmitter. Okay, you feel your phone vibrating in your right pocket. What tract will this information follow to get to the brain? Vibratory sense, is it ipsilateral or contralateral? Ipsilateral, so same side. So we know it's got to be right or left? Right side. Now what tract does it follow? The dorsal white column. That's all vibratory sense. Anterior spinal thalamic tract. What's that? The anterior one is light touch and pressure. Your lateral spinal thalamic tract is pain and temperature. Okay, last one for this one, then I have another short one after this. Okay, 24-year-old female fell off a ladder. You note right wrist flexion is weak, but the extension remains. So where is the injury? Okay, you lost right wrist flexion. What nerve goes to flexion of the wrist? So we'll study it for Friday. Okay. C7. Okay. Okay, who gets a thymectomy? What patients get offered that? Okay, myasthenia gravis. And why do they get it? Cancer. Okay, 24-year-old male, vision's getting worse. Been eating a lot of canned tuna. What comes from canned food? Okay, botulism comes from canned food, poorly canned foods. Okay, 45-year-old female with complaints of numbness and tingling in her toes moving up to her lower calf. 3 weeks ago, she was treated for Epstein-Barr. What's your diagnosis? Okay, good. Remember, anytime with Guillain-Barré, find out what happened beforehand. Obviously, she had a viral infection. What also is very important, the way that I described it. Symmetrical ascending paralysis. That's what Guillain-Barré is, an ascending paralysis. Started in the toes, started working its way up the calf. Okay, you see a patient in a coma with adducted upper arms and extended lower arms. You state a good prognosis. Are you correct? So they're like this. I can't show you on the exam, Gabby, I'm sorry. No, what kind of posturing is this? What's it called? Bad, yeah. Remember, this is the good one. Of both of them, this is the better one, but both of them are bad. So make sure you know the words for both of those. Decorticate or decerebrate. This disease has both upper and lower motor neuron symptoms, both upper and lower. What part of the spinal cord is this disease destroying? It's ALS. What does ALS destroy? The anterior great horn, so we don't have any connection between upper and lower. That's destroyed. What does it also destroy? What kind of tract? We only went over one. There's only one answer, but your cortical spinal tract. Okay, that's where the upper motor neuron comes down and it destroys that, so the upper is destroyed, and then the lower motor neuron because you destroyed the anterior great horn. Okay, antibodies against the acetylcholine receptor, and it affects more women than men. So we're talking about the acetylcholine receptor on the postsynaptic side. So which disease attacks the postsynaptic side? Okay, multiple sclerosis. What is the key problem in multiple sclerosis? Stripping the myelin away. That's all it is. Nothing with acetylcholine receptors. So make sure you remember that neurotransmitter, the pre and the post, which ones attack the pre, which ones are in the middle, and which one attacks the post. Okay, a patient just suffered a CVA, so a stroke. On physical exam, you notice they are trying to find the words to say, but they can't articulate it. Where's the problem? Okay, this is Broca's. Remember, Broca's is a motor problem. They comprehend language, they understand speech, they just can't articulate the sound. Wernicke's is a comprehension problem. They don't understand what you're saying, they don't make any sense, but they can say it without any problems. Okay, the patient has a Glasgow coma scale of 7. Which of the following treatments are contraindicated? Okay, what's the magic number to remember for this one? 8. Okay, below 8, intubate essentially, but below 8, you can't give any oral medications. They are not alert enough to be able to even swallow that stuff, so you can't give any orals. Supplemental O2 just goes through the nose. They're just going to breathe normally. They'll be fine. IV therapy, CT scans, not a problem there. It's just the orals because they can't swallow. Okay, 2 more. Which of the following is not associated with lower motor neuron lesions? This is not going to repeat, but which one is it? These are different ones. So which one is not lower motor neuron? Okay, very good. Your Babinskis. Okay, so last question. You guys are done for the day. I'll do the review Thursday night on YouTube. Patient was pinned between a car and a wall. Now they're complaining of numbness in the hips and loss of bowel function. What's the next step?
Yeah, well, I'll have them watch it.
Urgent MRI for this one. What are you worried about? Quad equine. Very good.
Whenever you have spinal cord compression, I know that, but I'm not